I was assigned the topic of short course radiation, and I'm going to explain to you why I think it's the best option. For one thing, it's safe, it's effective, it's cost effective, and it's efficient. And I think that in the future, we're all going to need to have things that are more cost effective and efficient. Now, one trial that Mike didn't mention is the Swedish Rectal trial, and this was a trial that did not include TME surgery, but included the blunt dissection surgery, and it was preoperative short course radiation followed by blunt dissection surgery versus surgery alone, and the updated results are now out to 13 years. There was a major benefit in local tumor control from 26% to 9% local failure. And it was more dramatic even in the node-positive patients, 43% relapse with surgery alone compared to 23% after preoperative short-course radiation. So survival and local control benefit compared to surgery alone. And that was the first real publication that established the role of this regimen. And following that, the Dutch TME trial looked at the same regimen, but with TME surgery, which importantly also had good quality surgical quality control. Surgeons had to be certified in the operation before participating. It was a large study. Median follow-up in the updated study is 12 years. Radiation did, as Mike mentioned, reduce local failure and overall recurrence from 11 to 5% at 2 years. In the subset of patients who had either R0 or R1 resection, it also reduced the rate of any recurrence, 32% to 20 versus 26%. And interestingly, they had pre-planned subset analyses, and the patients who had circumferential radial margin negative, which was 1,382 patients, the local recurrence rate was 9% versus 3%. That was statistically significant. There was a lower rate of any recurrence and a lower rate of disease-specific survival, but in the node-positive patients with negative margins, which was 435 patients, there was a local control and a survival benefit, a 10% survival benefit. So this was a pre-planned analysis. So importantly also, as Mike mentioned, the tumors that were higher in the rectum did not benefit from radiation. So I think this was a very large subset of patients with node-positive disease and circumferential negative margin negative that had a survival benefit with the use of radiation. So one of the concerns has been with using these large doses per day for over 1 week is about the long-term effects of radiation. And this is a comparison of surgery versus pre-op radiation and surgery. So there's no standard fractionation component here to compare to. But you can see that radiation did significantly increase various endpoints of bowel function, including incontinence, anal mucus loss, anal blood loss, and the use of pads. So that was something that did happen, but as Mike showed as well, the numbers are relatively small, and short course radiation is not unique in the fact that it causes these symptoms. The MRC CO7 trial from the UK was another large randomized trial that basically had the same randomization with preoperative short course radiation followed by a TME or TME alone, and postoperative chemoradiation only in the margin positive patients. The preoperative radiation reduced local failure 11% versus 4%, almost identical, very similar results to the Dutch TME trial. And disease-free survival was also improved with the use of preoperative therapy. In that study, they looked at the bowel function as well, and overall, you can see there was no difference in bowel function. You can see these two curves. In the fecal incontinence, these two lines are any kind of bother, and these are significant bother. So you see the significant bother lines are very low and very similar with or without the use of radiation. So very similar what Mike pointed out, there are some patients that have a negative impact after the use of radiation, short course radiation, but the numbers are not significantly high that have these severe symptoms. So there are, in addition to the two trials that Mike mentioned, there's another trial that's looking at a direct comparison. That's the Stockholm III trial, comparing short course radiation to standard fractionation radiation. In the Polish trial, as Mike said, there was a randomization of chemoradiation versus short course radiation, and there was an increase in path response to the use of chemoradiation, but no difference in sphincter preservation. One of the criticisms of this trial is that the surgeons just didn't change their mind. So when the tumor shrank, they didn't change the operation, which I think is the flaw there. And also they included all patients who even weren't at risk for APR in the analysis. So I agree the design flaw of having sphincter preservation as a primary endpoint is a problem in this study. But it didn't show a difference in local control, disease-free, or overall survival. In a 316 patient study, and many of the studies that Mike showed you are that were conducted in the U.S. that established the role of chemoradiation were about that large. So I think that the differences in local failure are in very low single digits. The TROG trial from Australia and New Zealand was a similar study comparing chemoradiation and short course radiation. It was powered to detect a small difference in local failure. And again, with the median follow-up of 5.9 months, there was no difference in local failure, very low single-digit differences. So I would argue not clinically significant differences in local failure. And also the grade 3 and 4 late toxicities were not different. Overall survival was not different. The Stockholm III trial is an interesting trial because it is asking the question that of whether or not surgery can be delayed after short course radiation, because prior to that study, the standard was immediate surgery within 1 week after doing radiation in 25 gray and 5 fractions. So the randomization is immediate surgery versus surgery at a more conventional interval after short course radiation, and then standard radiation followed by surgery. So allowing time for downstaging with the short course. So their initial publication on this came out a few years ago, and they reported the initial toxicity, and what they showed is that basically the type of surgery that was done was similar in all arms. There was a little bit higher dysfunctional stoma in the patients that had long course radiation. I'm not really actually sure what that means, dysfunctional stoma, but it was higher in the long course radiation. There was no evidence of any postoperative complication differences between short and long course, and the interval between radiation and surgery didn't seem to be a problem, unless the short course and the short course patients who were supposed to have surgery in a week, if that was delayed for any reason, actually let me just, I'll get to that. If that was delayed for any reason, there was a higher rate of postoperative complications. So it was overall 65% if there was a delay beyond 10 days, and this, for whatever reason, logistical or otherwise, there was a higher rate of complications. And this makes sense from the standpoint of the acute effects of radiation. The acute effects of radiation will start to peak at this interval. So if someone's having an operation at that time, they're healing from the radiation as well as trying to heal from the surgery. This does make sense. So the short course should probably either be delivered within, surgery should be delivered within 10 days, or if it's delayed and it's at a more conventional time frame, or beyond 17 days in this case, then it appears that the complication rates are not affected. So why is short course, with all these data showing that very similar outcomes to standard fractionation, why is short course not used in the U.S.? Is money the reason? I would argue that right now in the U.S. there's a strong trend towards delivering very convenient short course radiation with SBRT in 1 week, stereotactic radiation. Even pancreatic cancer is a popular, SBRT is being used at a low dose, 32 gray, very similar dose with a fancy technique. And it's very popular, but the reason that these things are popular is that the reimbursement is extremely high. I think the answer to this question, potentially of why no one uses short-course radiation in the U.S., is it has to do with the economics. People get paid about 5 times more. They get paid by the week, so they would prefer to give 5 weeks of radiation. So is 5 gray times 5 going to be increasingly used in the future? I think it will become more popular in the future because of an increased demand for care with an aging population, contraction of resources, and I think efficiency will need to be increased. We're going to all have bundled care plans, so we're going to need to be more efficient and more cost-effective. So in summary, short-course radiation is effective. There are multiple randomized trials showing very similar benefits to standard fraction radiation. It's safe with late side effects not clearly a concern. It's cost-effective and convenient.